Welcome back, everyone. I'm here with Dr. Ambert and Dr. Delcroix. In the next section, we'll discuss key presentations from the European Respiratory Society meeting and the annual CHEST meeting from just October of 2022. The ERS meeting occurred in early September in Barcelona. Dr. Delcroix, what were some of the most interesting data presented at ERS for you?
Well, what we have is, for example, some more discussion about study endpoints. And so we had a nice presentation from the Compare registry, Germany and other European countries, showing the value of an improvement in a certain parameter and this impact on mortality risk. So this is registry data showing that when you use only the 6-minute walk improvement, you have not really a good impact. An improvement doesn't mean a good impact on the mortality risk. When you use NT-proBNP alone, it's the same. You don't really impact the mortality risk. And it was pretty much in favor of composite improvement with multi-factors showing this. And it's a combination most of the time of non-invasive parameters, 6-minute walk, functional class, NT-proBNP. And they showed from studies with combined improvement endpoints that it is very well correlated with the mortality risk, that also you have a very significant number of patients who improved. And also they showed that the reason for strata classification at follow-up is very interesting, very well correlated with mortality, good predictor of mortality, but also showing a very important number of improvements. So we reach 50% of improvement in these patients, which is probably also valuable when you want to show that the drug is efficient. So this was really interesting.
Mark, you're familiar with the pulsar data of sotatercept and the concept of multi-component here. Can you just walk us through what was presented by Marius Hopper in terms of the patients that were on placebo versus drug and the multi-component analysis?
Yeah, indeed. It's very good to discuss that right after the commentary from Marion, because indeed we have different ways to analyze response to a treatment, but there is no better way than multi-component. And in fact, it is what we have discussed in the guidelines, where we have multi-component analysis and we then re-stratify patients. Here in the PULSAR trial, there was a willingness to measure, of course, pulmonary vascular resistance as a primary endpoint, and then walk distance, functional class. But the beauty of this kind of study is that you can put it all in one picture and provide information on multi-component endpoint. And what is really important in the multi-component endpoint analysis is that on placebo, you do not achieve everything. You may achieve an improvement in walk distance, you may achieve an improvement in functional class. That's where you have the most important placebo effect, but you rarely have more than that. And when you want to combine functional class, NT-proBNP, and walk distance, in order to show that all of them improve to reach a multi-component positive endpoint, then the placebo effect is very, very minimal, while the drug effect is much more impressive. So at the end of the day, I think the message from this study is that you may obtain one single improvement in a parameter, but what matters most is a multi-component which integrates the whole spectrum of improvement in a given patient.
And therefore defines, in a way, the way when we follow up patients that we have to consider each of the parameters, the risk factors.
Exactly. It's very, I think it echoes very well what we have discussed in the guideline.
There are some long-term data that is presented at the meeting at ERS regarding the treatment of ILD with inhaled treprostinil. Do you believe in Europe and for the rest of the world that pH matters in ILD. In other words, number one, that it's important to pick out pH in group 3, and that two, that there's an opportunity to treat here. Marian?
Yes,
yeah, Marion, please.
I think there is now a lot of evidence that that started with probably the ASPIRE registry from UK, where you show that having pH in patients with lung disease and including the patients with interstitial lung disease, that they had a very important pH had a very important impact on survival. And the data who were presented at the ERS were from the Spanish registry. The Spanish registry showing then when you have even very limited increase in pressure, and we mean then 21 to 24, with a PVR of more than 3, you have an important impact on the survival. Also, that this pulmonary hypertension is much more frequent in ILD than in COPD, in fact.
We have now the long-term data on the INCREASE study that was talked about here. This study was the inhaled treprostinil versus placebo and an open label extension phase looking at the outcomes of these patients. But the question I would ask you is, it's approved in the United States for the treatment of group 3 pH. Are you using it practically in Europe, and is it feasible?
Well, if I start, in Europe, it's not approved and reimbursed yet, but we have been very impressed by your data published in the New England Journal of Medicine, because the key question is elevated pulmonary pressure and resistance. It's a marker of poor prognosis, but is it treatable? And I think for the very first time in the INCREASE trial, you showed that treating pulmonary hypertension in ILD-related or associated pulmonary hypertension translates into better walk distance and seemingly also better long-term outcomes. And this open label extension is interesting because it shows sustained efficacy. And I would like to say that in Europe and in the European guidelines, we have maintained the possibility to treat patients with oral drugs, mostly PDE5 inhibitors, but on a case-per-case basis in an expert center with a clear definition of endpoints and the possibility to stop the treatment if it is not efficacious. Of course, with inhaled treprostinil, there is now another area which is opening, and we will follow that with great interest.
Thank you, Mark. The meeting in CHEST that occurred in October in Nashville for the first time, at least as far as I can remember, and the first meeting in the US in 3 years where we saw our PH colleagues again face to face. What were some of the most interesting data presented for you, Marian? And I'll start with a mention of the trial of dose response, or the outcome of dose response analysis looking at inhaled treprostinil.
Yeah, well, it's interesting. Well, we don't have, as you say, we have not so much experience in Europe. We didn't participate to this trial. Anyway, you see that there is a dose-response relationship on the effect on 6-minute walk and on the functional class. Anyway, it's very documentary for this and a good addition to the existing evidence. And so we'll see if it matters or have an impact on the approval of these drugs.
Mark, there's also some data that was presented on the open label extension of the FREEDOM study, which was oral treprostinil looking at overall survival. And this was a risk of death versus placebo over up to 4 years.
Yeah, no, it's interesting. I value very much randomized controlled trials in the field of pulmonary hypertension. And each time we have a study, we have to do it right, and we have to follow the patients long term. So I was very happy to see this data presented by Jim White, and it showed that oral treprostinil was associated with a risk reduction for death versus placebo at study closure. And that's really, I think, another information which is interesting to consider in the vast category of the prostacyclin field, where we have several drugs associated with better outcomes, including, of course, the intravenous, the subcutaneous, the inhaled, and now the oral drugs. And this is, I think, very good to have, and these papers are important for the field and the community.
Thank you. Finally, we have a presentation from CHEST, where they talked about epigenetic modulation using a drug called CS1. It's a histone deacetylase inhibition that has disease-modifying potential. And essentially what was presented was the rationale and the trial design for this epigenetic modulation. Is this something that we should be keyed into? It's a phase 2 trial, so it's moving now towards the real clinical testing. How promising is it, and is it just another one of the chemical modifications that may or may not hit, or do you think it's further along in development?
Yeah, if I can start, I mean, I'm always in favor of innovation. And I'm really very happy to see that pulmonary hypertension as a field is one of the most active fields of cardiopulmonary medicine. Of course, we have new kids on the block. We have drugs targeting the activin pathway, the BMPR2 activin ratio balance. We have new data coming soon on PDGF inhibition. But I think that the epigenetic component to PAH is important to test in well-designed randomized control trials. Of course, we are very, very early in the field, and the studies will be small. They will give us a feeling on whether we should pursue further. In the future also, we will have to position these new agents in the new field of pulmonary hypertension treatment, which is very likely to evolve in the next few months.
One aspect of this particular trial, and it's only 30 patients in phase 2, and it's mostly looking at safety and tolerability, but the secondary endpoints are all those that we're familiar with. In addition, there is the use of the CardioMEMS device, which is the small implanted device that measures DPDT and other things inside the pulmonary circulation beat by beat. Marion, do you have any experience with this in your center? And do you have any comments on whether or not this is a relevant and important measure?
Well, we have experience with CardioMEMS for patients with left heart disease, not for pulmonary hypertension. And when I see a device which measures only pressure, I always worry what was the cardiac output. So, well, perhaps we will have interesting data, but anyway, it's not complete the data of the hemodynamics of the pulmonary circulation.
Mark, how about at your center? Are they using it in France in any studies? And do you find that it's potentially useful data to have beat by beat measurements?
Yeah, we follow the same thinking than Marion. We have a lot of information from the left heart world. We wish to have a more advanced CardioMEM measurements with certainly more than pressure. But as you say, we can estimate resistance, and we follow that with great interest. As I said before, I mean, I'm in favor of innovation. If this way of measuring pressure is an added value as compared to what we used to do classically, I will be very, very happy. But for the moment, I think it's still work in progress, and I follow that in the field of PAH, of course, with great interest.
Thank you both. I'll just summarize then for this recap of the ERS and CHEST meetings that most of what we're still seeing are different takes on how to analyze the outcomes of patients with the current 3 pathways that we have, the prostacyclin, the endothelin, the PDE5 pathway. And the main point here, I think, that's important to remember as specialists and as treaters is that we have ways to modify the disease and improve the disease, but it remains a fatal disease. It remains incurable. So until we have better molecules that can really get at the core of what the disease process underlying is, we're still going to be trying to improve strategies that are incremental and may not be game-changing. There are, however, we've seen emerging therapies, and we've seen recent reports now of completion of phase 3 top-line data, and these may provide new options as we go forward with the management of PAH. Given the fact that the PAH is still very, very deadly, and that there are multiple centers across the world finding different molecules and different targets, hopefully this will result in clinically important improvements for outcomes in our patients. Thank you again for joining us. Stay tuned for our final talk